Okay, so if you think about the question, looking at, yeah, that's great. So the key symptoms here are difficulty swallowing during meals, and a palpable lump on the side of the neck. So it's if you're thinking about what that could be, narrowing it down, thinking about the patient's age, any comorbidities, any risk factors that it gives. It doesn't give a lot of information in this question, but the most likely, because of lacking other details that would kind of point you in the direction of the other answers, the most likely diagnosis here is pharyngeal pouch. Okay, so this question, you will want to have a look at the images. So the images are quite important in this question. Clue. Okay, give me your answers. What do you think it is? Okay, absolutely. C. Yeah, you got it right. C. So in this question, so let's have a look at what is a perforated viscus. So you might have not heard of it in those terms before. So it's a perforation. So where the bowel has got a hole in it, basically, and this causes air to go into the underneath the diaphragm. So if we could we go back to the previous slide? So if you look at the maybe even the previous one, if you're looking at the image there, the X-ray, so we assume that this is a an erect X-ray, so they're standing up when they've had the X-ray done, so the air travels upwards. If you look underneath the diaphragm on that, it's clear on the X-ray on the right-hand side. You can see a little bit of air under the diaphragm, where you see that line going where the diaphragm is. Underneath there's a little bit of air, and so that shows you that there's been a perforation, and so that's kind of the main clue as to why it's after that in this question. And so next slide, please. Next slide. So looking at some of the reasons as to why it's not the other ones. So if you go on to the next slide. Okay, so have a little read of these. These are the reasons as to why it's not pancreatitis. Normally, that would be kind of pain that goes to the back. So it'd be epigastric pain radiating to the back, thinking about raised amylase, things like that. Bowel obstruction. So you might have been thinking that it was bowel obstruction because the abdominal X-ray looked a bit different to a normal one. But because of the air under the diaphragm, you know that it's perforated. So it might have been that it was bowel obstruction leading to perforation. We don't have enough information to know that, but yeah, so it's less likely to be diverticulitis, and that presents in quite a different way. And it'd be more of a chronic thing, less of a surgical emergency. Renal colic. So colic is the description of pain that comes and goes, that is very, very very painful. When you see a patient with colic, they'll be hunched over, in pain, writhing, and it will kind of come and go, get really bad, and then ease a little bit. Whereas there's a difference between colicky pain and peritonitis. Peritonitis, you'll see patients and they'll be stiff. They won't want to move. Any movements will mean that they're in more pain, so they'll be really, really still. Whereas colic, they're more likely to be kind of moving around in quite a lot of pain. So it's no suggestion of that in the question. So yeah, next slide, please. Okay, so approaching this one, so thinking about abdominal pain, many differentials you could think of with that. The fact that they've had cholecystectomy in the last previously, you're thinking potentially there's something going on. Previous bowel surgery makes you a little bit suspicious of perforations, suspicious, depending on how recent the surgery was. You're thinking, are there any surgical complications? We don't know how recent it was, so we can't necessarily know that at the moment. So they're pyrexial, tachycardic, makes you think this is a bit more worrying than something like diverticulitis that's a little bit more chronic. So yeah, so you want to kind of pick out the key points in each of the questions, and then it's all about recognizing the patterns of questions that you've seen before that are similar to this, that will then help you come to the right answer. Next slide, please. Okay, so this is the third question, a little bit more wordy. So have a little read of this. this is a little bit more of a tricky question. So if you're struggling and not understanding what's going on, don't worry. The closer you get to the exam, you'll have come across questions like this a bit more. If you know it, that's great. Okay. They might have needed a little bit more time. I don't know. I take ages to read. Go back for just for a second, maybe. Okay, you can probably move on. Okay, so have a little look at those answers. Think about what they all mean, what you're thinking the diagnosis is of this patient, what's most important piece of management for them. Okay. Okay, what are your answers to this one? I can see you're finding this one a little bit more tricky. Yeah, it's a harder question, this one. Absolutely, Cherry. Absolutely right. Yeah, D. So D is the right answer. Um, so right, so why is D the right answer? So let's go back to the question. Let's think about this question a little bit. So so you've got Sarah, 17-year-old, so young girl, has come in, and she was diagnosed with familial adenomatous polyposis, FAP. And for those of you who don't know what FAP is, it would have been difficult for you to answer the question if you didn't know what that was. It's a genetic condition that develops where you have lots of polyps that develop in your bowel, and these polyps can then turn into cancer. So if you look, there's a history of this condition in the family. So colon cancer at quite a young age of 37 and 39. Normally, you wouldn't expect colon cancer to be to someone at least in their late 50s, in the early 60s. That would normally be kind of the earliest you would expect colon cancer. But as you can see, that's not always the case. And someone with a condition like familial, like FAP, they're more likely to have kind of cancer earlier. And so they've had a colonoscopy which showed polyps. And so if you go to the answers, we'll have a look at the answers and kind of rule out certain answers. And so when it comes to managing conditions, there's important things to remember. So there's ways in which they can ask the question. So one of the ways they can ask the question is, what's the most important initial management that you need to do in this patient? So when they're asking that question, what they're asking for is, what are you, as a doctor who is maybe junior, what are you going to do to maybe stabilize the patient? What are you going to do first to help the patient? Is that give them fluids? Is that give them antibiotics? What is the initial management that you would do? Maybe the first thing that you would do. It might not be the thing that cures the condition. It might be the thing that's their management long term, but it's the initial thing that is to help the patient initially. Another thing that they'll say is they might say, what is the definitive management of this condition? In this situation, they've said the next step in management. So that's kind of a little bit in between the both. It's neither initial nor like definitive, but it's wanting you to know the next step. And in this case, for FAP, you would remove part of the colon. So if you go to the answers, next slide, please. Yeah, so if you look at the answers, so protocolectomy is a removal of part of the bowel. So you're taking away part of the bowel to remove the number of polyps, because those polyps could develop into cancer down the line. And so it's kind of a prophylactic treatment to prevent colon cancer, because they have a strong family history of colon cancer at a young age. And so it indicates that the NHS guidelines would want this girl to have a protocolectomy and anastomosis. Yeah, so if you go on to the next slide, just to have a look at why it's not the other ones. So quickly have a brief look over them. it wouldn't be an endoscopy because they've already had an endoscopy. It wouldn't show anything else. NSAID, that is part of the management of FAP, but it's wanting you to realize that the definitive management is actually to take part of the colon out. Okay, next slide. We'll go on to the next question. Okay. Okay. So have no worries that you're late. We're glad to have you. So have a little read of this question. So we're going through gastroenterology today. So we've got a 37-year-old named Sarah. She comes into the emergency department by the GP because she's had jaundice. So looking at the blood results and looking at the history, what are you thinking of in terms of what the most likely diagnosis is for this lady? Okay, so have a think before we show you what the possible answers are. Think of what causes of jaundice you know, and what pattern of jaundice this could be. Mark can answer that question. Okay, next slide, please. Okay, so these are your answers. So have a little think and then put your answer in the chat when you know it. Okay, so Sarah's on the ball today. So it is D, common duct stones. So let's think about why it's D. So if you go to the next slide. So they have jaundice. So it's an obstructive jaundice pattern, because you see with obstructive jaundice, you see that they have pale stools, and dark urine. And why? So when we say obstructive jaundice, it means that the tract, the basically where bile goes, it's obstructed, and that causes patients to get jaundice. There is it's a more complicated reason as to why you get jaundice, but I'm not going to go into that today. What we're doing today is we're kind of looking at past questions. There is more reasons as to why people get jaundice, different types of jaundice. We could talk about that for a whole session. So we're not going to do that today. But in this situation, there are reasons as to why it's less likely to be the other answers in this question. So a lot of these answers would cause jaundice, but due to the nature of the question, it's kind of quite a straightforward obstructive jaundice picture, without any other features of any of the other conditions. So if you move on to the next slide, we can have a little look at, okay, so have a little read of these as to why it's not pancreatic cancer, why it's not cholangiocarcinoma. These are conditions that can cause jaundice. They're a little bit more rare. Pancreatic cancer, you might expect that they would be older. So this is in a 37-year-old. I mean, it happens, but unlikely to have pancreatic cancer. And they more likely have things like weight loss, fatigue, cholangiocarcinoma. It's another cause, also rare. You'd also expect things like weight loss, fatigue, abdominal pain, and it doesn't show any of these symptoms in that. Next slide, please. Cirrhosis of the liver, so scarring of the liver. Yeah, there's no signs of any liver cirrhosis on examination, anything like that. And hepatitis B, there's no kind of things that would make you think about hepatitis B. Often with different forms of hepatitis, you might be looking for things like foreign travel, fatigue, fever, unexplained fevers, kind of that's more what you're looking for with hepatitis. So next slide. That's great. So in terms of how you'd approach this question, we'll have a little think about that. So the key things to think about in this question are colicky pain. Spoke about that earlier. So it's right upper quadrant pain. So the fact that there's an intolerance to fatty foods, that's suggestive of an obstructive jaundice picture, dark urine, pale stools, and then the investigations, they have high bilirubin because they're jaundiced, and yeah, that's basically it. Reasonably straightforward question, that one. Very common kind of question that. Okay, next slide. Next question. Okay, have a little read of this one. So you've now got a 34-year-old woman. It's called Sarah. A lot of these people called Sarah. Comes to the emergency room, decreased appetite, nausea, vomiting, episodic abdominal pain over the last couple of months. Pain is sharp in nature, colicky, and lasts for about an hour after meals. Have a little think about what could be going on here. Okay, could you go to the answers, please? Next slide, please. Okay, looking at those answers, what do you think is going on here? Okay, put your answers in the chat when you've got that. Okay, this is a bit of a tricky one, as I think you're finding. Okay, so if we go on to the answer. Okay, so it's low bone mineral density. So what is it, low bone mineral density? So you're thinking about the clinical presentation. So they've come in with decreased appetite, nausea, vomiting, abdominal pain, light stools, and then they've got tenderness in the right upper quadrant. So this is consistent with biliary obstruction. So that can be caused by lots of things: gallstones, tumors, strictures. So biliary obstruction itself can then lead to low bone mineral density because it can interfere with the absorption of vitamin D. And so this question is asking a little bit further down the line. So wanting you to know that it's biliary obstruction that's causing the presentation and what biliary obstruction can lead to in this kind of in these kind of list of things that. So that was what it was asking for in this question. So have a little think. You might not be familiar with some of the answers here, and that's all right. If you're at the start of like preparing for this exam, you'll get more familiar with these things later. So you go on to the next slide, thinking about what the other answers are. So glossitis, inflammation of the tongue, megaloblastic anemia. They do like testing anemia in these questions in the AKT. So it's really good to have a good understanding of different types of anemia. It wasn't what it was asking for in this question. They would make it a little bit more. They have a way of asking questions that are related to anemia. You kind of pick up certain things that it's wanting you to know about it. And the more questions you do, the more you're able to see when it's asking you about anemia or not. So, and the other two, yeah, there's no kind of reason as to why it would be the other two. Okay, that's great. Okay, next question. Okay, so you've got now a 32-year-old man comes in, 10-hour history of severe right upper quadrant abdominal pain after he ate a fatty meal. No significant history. He's got normal temperature, pulse is normal, blood pressure is normal. What's going on? Look at the blood results. Okay, and what's it's asking, and think about the question as well. What I like to do when answering these questions is look at the main history. I like briefly read the main history and then go right to the end of the question and read what it's asking me. And then I'll go back and read the question properly. Different people do it differently. That's what I like to do, just so I have a bit more of an idea of what it's asking me to do. Then I can think properly. But whatever way suits you. Okay, so if you have a think about that and then have a little look at the answers. Okay, so it's asking where the stone is in relation to each other. So where do you think the stone is here? Have a little think, and then put your answers in the chat. So I think this question looks harder than it is. That's absolutely right. Common bile duct. So it's one of those questions that it makes you so with right upper quadrant pain. So it's indicative of cholelithiasis, which basically is a very fancy name for a stone being stuck. And it can cause obstruction, which can lead to jaundice and elevated liver enzymes. So very commonly, this presentation, the most common area where it will a stone will lodge is the common bile duct. And so if you go on to the next slide as to why it's not the other answers. So yeah, so basically it wouldn't be a common hepatic duct. That wouldn't lead to this kind of clinical picture. Cystic duct, it could be there, but it's unlikely to cause things like jaundice and liver enzymes. It would be less likely to cause symptoms like that. If it was in the gallbladder neck, it also wouldn't cause jaundice. And if it was in the fundus, it it wouldn't cause symptoms often. Often, if it was in the fundus, it wouldn't even cause symptoms that you would know about. Often, with the location of the stone, often symptoms are only caused if it's actually in the common bile duct. That's the area. Normally, if you see common bile duct as the answer, that's the right answer. That's a really bad way of thinking about it, but it's normally the way. So, yeah, very bad technique to use in order to understand what's going on. But if there's a question and then the answer has common bile duct, it's normally the correct answer. Okay, next question. We'll move on from that one. We've done a lot of biliary things. Okay, so 68-year-old woman presents to the emergency department with bleeding. You can read that yourself. Have a little read, think about what's going on. And it's wanting in this question you to know what the most likely diagnosis is. Okay, next slide, please. Okay, have a look at those answers, and then when you're ready, put your answers in the chat. Give you a couple of seconds because this is not necessarily a straightforward one. If it's a guess, Mariam, you've got it absolutely right. So the answer is A. Perfect, good work. So why is the answer A? What is angiodysplasia? So it's basically a vascular abnormality in the blood vessels, which can lead to bleeding. It's often seen in elderly patients where they have painless rectal bleeding, a sudden drop in the blood pressure, and that's quite characteristic of angiodysplasia. Okay, so if we go back to the question, we'll have a look at it because I think some of you might have struggled with this one, which is reasonable. So what are the key kind of clinical features of this question? So you know that they're bleeding per rectum, you know that they're hypotensive, and you know that they have some comorbidities. So they have hypertension and they are diabetic, and they're also on aspirin. So thinking about what can cause acute hypotension and rectal bleeding, that kind of will give you the clue as to what's going on. It's quite a sudden onset. And so of all the things, ischemic colitis is like another word for angiodysplasia. So it no, it's not. Let's go on to the reasons as to why it's not the other answers. If we can go on to the next slide. Okay, so it wouldn't be a colon cancer, colon tumor. Normally wouldn't lead to a presentation of hypertension like that. You're thinking of other symptoms with colon cancer. Diverticular disease would cause rectal bleeding, as would colon cancer, but you're unlikely also to see the like lack of hemodynamic stability where the blood pressure drops really suddenly like that. It's also not something like Crohn's, because it wouldn't cause hypertension. So really the key thing in this question was the hypertension, the drop in blood pressure, that would make you think it was A. So it was a tricky question, but we will move on. Okay, a bit of a shorter question, nice and quick. Number 8. So 68-year-old woman visits a GP with bright red blood on the outside of her stool over the past 6 months. She reports incomplete sensation after evacuating her bowels. Okay. Right. Does anyone have an idea what this could be without looking at the answers? Because that's where you want to get to. So it's good having good multiple choice technique, being able to eliminate things. But what you want to get to eventually is to be able to answer the question without. Sometimes the questions don't allow you to. Let's look at the answers because it's a little bit broad. It'll help you out on this one. So we've got an adenocarcinoma. It's a lovely guess. Okay, so there's a few things going on in this question. Bright rectal bleeding. So the difference between bright blood, PR bleed, and dark blood will show you the location of the bleed. If it's brighter, it's more likely to be closer to the rectum. And if it's darker, it's more likely to be higher up in the tract. So the answer to this one is C. So why is it C? So have a think about that. So it's mixed blood with the stool. That's indicative of adenocarcinoma. And it's right-sided tumors would present with anemia, weight loss, and abdominal pain. If you presented with left-sided tumor, it's more likely to present with blood in the stool, and change in bowel habit, and tenesmus. Does anyone know what tenesmus is? Anyone give me an answer to that? Put it in the chat if you know what tenesmus is. It's a symptom. Any idea? Give you a second. Okay, so it's basically what was described in the question. It's an urge to go to the bathroom, so an urge to empty your bowels without kind of being able to, without being able to go. So that's it's quite a horrible symptom actually. It's that feeling of constantly feeling like you're needing to go but not being able to, and that's something that you would find in colon cancer. So if we move on to why it's not the other ones, it's not an anal fissure. So in these they like asking these questions a lot. This is quite a common. I would, if I were you guys, if I was to sit it again, I think in my exam, so I sat the AKT a couple of months ago now. I think there was like four questions on differentiating between different types of rectal bleeding. So whether that be anal fissure, hemorrhoids, diverticular disease, it really wanted you to be able. So thinking about this, so it's one of those questions that they ask a lot. And so really easy marks. If you can differentiate between these different things, really, really, really easy to be able to, because often what they won't even want you to know what they want you to do with how to treat an anal fissure. They'll often just want you to know the difference between the different ones. So it's something to look at. So things that you're thinking about with this kind of question, does it cause pain on defecation? That's one of your questions that some of them do cause pain on defecation, some of them don't. Is the bleeding related to defecation? Is the bleeding, what's the amount of bleeding? Is the blood bright red, dark red, even darker color? Is the stool really dark? Are there any on examination of the anus? Is there anything that you can see visually on the externally? That will give you an idea. It will be able to eliminate the different. So you had things like anal fissure, diverticular disease, hemorrhoids. So what I would do is, if I were you, is I'd look at those things. I can't really go through it all now, but thinking about which question, which condition would be most likely in different situations, and maybe make yourself a table, or however you like to do it, and think about each of these conditions, because it'll be a lifesaver when you come towards the exam to just be able to go, I know it's that straight away. And then these questions are really easy. Next slide, please. Okie dokie. Okay, so 27-year-old man, painful oral ulcers. Okay, so when you've done these questions a lot, you'll have certain things that you're thinking about when they're talking about ulcers. So what, before we answer the question, what kind of conditions cause ulcers, and what are you thinking about with ulcers? Any thoughts? Any ideas at all? So you're thinking about like inflammatory bowel disease. That's one of the things you're thinking about. You're also thinking about things like Beckett's syndrome. Um, yeah, so probably giving you a bit of a hint here, but keep reading the question and then we'll move on to the answers. Okay, so if you move on to the answers, okay, so there you go. Here are some of the answers. So if you're thinking about these, you might want to, if we keep on this slide for a second, so someone goes for B. Okay. So if we go back to the question, just give a couple more people opportunity to answer it. Have another quick look over it. Absolutely, you spot on, guys. B. Yeah, so let's move. Let's go to the answers. Let's see why it's B and what is B. So idiopathic. So it's basically ulcers. So can cause by things like trauma. There's no in the question, it's not giving you any indication that it's any of these other conditions that also do cause ulcerations. So things like Beckett's or Bessett's, I don't know how you pronounce that, Crohn's, herpes simplex, oral carcinoma. This is a lot of what the AKT is. It's wanting you to differentiate between different conditions, having an idea of what the what each can do. Why is Crohn's different to Beckett's? Why is herpes different to Crohn's? What is it about each of these individual conditions that make them unique? And when they're asking you a question, you can see something and go, I know it's that because of this. I know it's that because of that. So in this question, if we go on to the why it's not the other answers, yeah, so the fact that in oral carcinoma, so this one's more of a elimination question. Absolutely, it can be because of that. That's very good. Very good. Thank you. Um, it can be because can be any kind of sort of trauma. They're more likely to cause ulceration in the mouth. Oral carcinomas are things where if you have an ulcer that is non-healing, that's making you think of oral carcinoma. If it's kind of a persistent ulcer over months, you want to be suspicious of kind of a squamous cell carcinoma, so an oral carcinoma of the mouth. Um, if herpes simplex, you wanting to think of things like a burning sensation, like kind of more urinary symptoms. You're also thinking of kind of a history of like sex with multiple partners, those kind of things. Crohn's disease, it's kind of more, you would expect more bowel symptoms. You would expect there to be a kind of a chronic history. It's not very indicative of Crohn's. Um, this is Beckett's is could have been the correct answer, but you'd be more thinking that there'd be things like genital ulcers as well, which wasn't mentioned in the question. So this one I think is more of process of elimination. So it's not that, it's not that, it's not that, and it's not that. Because it doesn't actually give you a lot of information. And that's the thing to remember with these questions. It they are good for they're what they test you on in the exams, but for clinical practice, they are you won't it won't always be the case that all of these conditions will present classically as they want you to answer it in exams. So when you're thinking about cases in real life, it is important to remember that even though it's maybe got that classical thing that it might be because of Crohn's or it might be because of herpes, that you need to keep an open mind when you're thinking about different causes of things like ulcers. It won't always be the textbook answer in real life, but in multiple choice answers, it will. So that's something to keep in mind when you're preparing for this exam. Think about the classical presentations of all these conditions in the MLA content map that all these questions are based on. Okay, next slide, please. Okay, last question now. So we've got a 38-year-old woman presents with difficulty swallowing over the last 4 months. So we've got another dysphagia question. Okay. What's the most important investigation in this case? Next slide, please. Okay, so what are you thinking about here? Absolutely, endoscopy. Great answer. Perfect answer. That's exactly right. Um, so if we go and have a little look at the question again. So difficulty swallowing last 4 months. So pain of retrosternal pain and regurgitation, even though there's no signs of like malignancy at this point. Difficulty swallowing is a red flag sign in itself. And so a 38-year-old woman with kind of indigestion type symptoms, regurgitation, retrosternal pain. This kind of question would be they present to you in general practice, so in primary care. What investigation is most important? So you're wanting to rule out something like a malignancy, because even though it's telling you that there's no sign of malignancy, you are wanting to still do an endoscopy to rule out signs of malignancy in this case. So yeah, there you go. And also, it's not just kind of signs of malignancy. So in this case, you're also thinking as reasons as to why. So the most likely diagnosis in this case is something like GORD, so gastroesophageal reflux disease, which is causing the reflux. So when you do an endoscopy, it actually can give you an idea of what's causing the condition. Something like maybe Barrett's esophagus. other kind of problems with the esophagus that could be leading to problems with stomach acid kind of moving up the esophagus and causing this irritation. That's the symptoms that they're experiencing. So yeah, you want to do an endoscopy to see what's going on, basically. None of the other studies in this case would be very relevant. Yeah. And you wouldn't want to have a patient have a CT for no reason. A CT wouldn't be very good in this instance. Radiation for no reason. Chest X-ray wouldn't give you a lot of information. Barium swallow. It is good. It is a good investigation. But that would be something you'd be thinking of if on the endoscopy you weren't thinking of something like GORD, then you might do a barium swallow later on. But at this point, with the initial investigation, like I was speaking about earlier with the initial management and definitive management diagnosis, it might ask for initial workup or definitive diagnosis. So those differentiations are important when you're answering these questions. So that's it. I hope you found that useful today. Thank you for joining us. Thanks for participating in the session this morning. Does anyone have any questions before we end?